My name is Ashlie Tronnes, and I'm one of the MFMs at Northwest Perinatal. And in this talk, I'm going to be talking about management of twins in the first trimester. So my objectives today are going to be to review the risks in a twin gestation, and then based on those risks, we'll discuss important considerations for the first prenatal visit, and with that as well outline an ultrasound surveillance plan for the pregnancy. Okay, so I don't know how many of you have ever felt this way, but this is sometimes how I feel when I meet with a family that just found out that they're having twins. For those of you not familiar with Saturday Night Live, Debbie Downer is a character who often has nothing good to say. And, you know, you have this couple sitting there smiling, they've just conceived their twins, and I'm going to tell them everything that might go wrong. So in the next few slides, I'm going to share with you the Debbie Downers of a twin gestation. But I do think it's important to review that with families because it does give them the groundwork for why we're going to do all the ultrasounds and recommend all the different changes to their management. And hopefully, you know, justify what we're doing for them. I like to think of the risks for a twin gestation in different buckets, and this is how I talk to families. There's a maternal bucket, an obstetric bucket, and then the fetal bucket. For the purposes of this talk, I've combined the maternal and obstetric risk factors into this slide, and it includes hypertensive disease, which we see in about 10 to 20% of twin gestations. There's an increased risk for gestational diabetes, anemia, abruption, cesarean delivery, postpartum hemorrhage, and venous thromboembolism. The fetal bucket is a little bit more complicated, but overall we see an increased risk in morbidity and mortality in twin gestations. The highest risk is likely in the monochorionic monoamniotic twins, but still seen in our monochorionic diamniotic twins as well as dichorionic diamniotic twins, carrying probably the lowest risk of the three, but still increased above what we would see in a singleton gestation. As we know, twins on average deliver earlier at 35 weeks. And in general, twin gestations have a higher risk of a shorter cervix than the general population. And as we talked about, or Dr. Lee talked about earlier, we have limited treatments to help reduce that risk of preterm birth. There's an increased risk of aneuploidy in twins, and some of that might be due to the fact that twins are seen more commonly in women with advanced maternal age, and they're in general at a higher risk for aneuploidy, but also you're carrying two fetuses, and that in and of itself increases the overall risk to the gestation for aneuploidy. Anomalies are also seen at increased frequency, approximately 6 to 8% for the entire gestation. And monochorionic twins also have an increased risk for cardiac anomalies. Growth restriction is more common. We see that in 10 to 15%. And I have a little diagram there on the left, just displaying the early unequal sharing that twins can experience. And this can be seen with IUGR, growth restriction, but also as a part of twin-twin transfusion syndrome. For monochorionic twins, twin-twin transfusion syndrome is a unique complication that occurs in 10 to 15% of those gestations. And less commonly, but also noteworthy, is twin anemia polycythemia sequence and twin reversed arterial perfusion, which are, like I said, less frequent, but complications that we as MFMs sometimes see and manage in a monochorionic gestation. I wanted to spend a few minutes talking about twin-twin transfusion syndrome, since this is something that we're going to recommend screening for quite significantly throughout the monochorionic pregnancy. And I think understanding it helps us in counseling families and also understanding the process. So it's not a physical anomaly in the twins, but rather an abnormal arterial venous connection or unequal sharing that's occurring. And so what you have is essentially we label one of the twins as the donor, and then there's a recipient. And that donor twin has an artery that's going back to the placenta where it's going to get nutrient-rich oxygen blood flow from the placenta. And then normally that artery would connect to a vein in that same fetus and go back to that fetus to deliver that oxygen and nutrient-rich blood. However, in twin-twin transfusion syndrome, that artery connects to an abnormal anastomosis with a vein in the other twin. And that blood flow then is given to the recipient. Now, as long as there are balanced connections between the recipient and the donor, there's a net equal transfusion and no twin-twin transfusion syndrome is expected to occur. If there's an imbalance in the number of anastomoses going from one twin to the other, you see this imbalance develop. And the donor essentially is getting less oxygen, nutrient-rich blood, and the recipient more. Now, the donor tries to be smart and says, I'm going to preferentially give this blood flow, this oxygen-rich blood, to organs that need it, like my heart and brain, and less to my kidneys. Those babies then produce less urine, and we see oligohydramnios. The recipient, on the other hand, is getting more. They have an increase in blood volume, the heart is pumping more, the kidneys see more fluid, they urinate more, they develop polyhydramnios. And they can also develop hydrops because of the increased pump demand, and that can even turn into fetal demise. The donor is also at similar risk because of decreased oxygen-rich blood flow, and it can have injury to critical organs like the kidneys and brain, and also experience an increased risk for demise due to that. We diagnose this with ultrasound, where we're looking at oligohydramnios and polyhydramnios in a monochorionic twin pair. There is, with these unequal connections between the twins, there's also an increased risk that one twin, because of unequal sharing, may not grow as much. And so that is something that we sometimes see, but not necessarily part of the criteria that we're using to diagnose this. So it is important to really come down on what is the critical abnormality that's happening in the twins, because you can have, with unequal sharing, no twin-twin transfusion, but just one twin that is smaller than the other because of an unequal distribution of the placenta to that twin. And understanding the underlying problem or issue directly correlates into what kind of treatment is needed. And I think that's an area where we as MFM can be helpful if it's uncertain. Without treatment, twin-twin transfusion syndrome has a very high risk of mortality, 70 to 80%. Because these twins also share the placenta, if one twin dies, the other is at very high risk of demise. And if it doesn't demise, then upwards of 40% risk of some form of neurologic injury. And I think that while it sounds really scary, and it's important to understand. Treatment can improve outcomes, and there are a variety of treatments that are available. The most, right now, the one that we think of as the most successful is laser therapy, and it can improve the possibility of at least one survivor, if not both. And so screening, again, will allow us to detect this early and potentially refer these families for treatment that could greatly impact their pregnancy. I wanted to briefly mention monoamniotic twins and some of the unique complications that they may experience. So monoamniotic twins have an increased risk for various issues, including cord entanglement, since they share a bag of water. At less than 20 weeks, they have about a 15% risk of double intrauterine fetal demise due to cord entanglement accidents. And as you proceed in pregnancy, that risk declines and is approximately 5%. They also can have twin-twin transfusion syndrome, and we see that about 5% of these cases, and growth restriction as well. Monoamniotic twins have a high rate of discordant anomalies, and typically we're scheduling and planning a preterm delivery between 32 and 34 weeks if it hasn't been indicated before. So with all of these risks in mind, I have some recommendations for the first visit. First, it's really important to discuss adequate nutrition. All women should be taking a prenatal vitamin, supplemental folic acid, additional iron, And we should talk to them about caloric intake and weight gain guidelines at the very first visit. Unfortunately, many of our insurance companies don't cover nutritional consultation for twins, but some may, or they may have it available through their work, and I think that could also be a helpful tool. Genetic testing should be discussed and offered to all twin pregnancies. Many of our families have gone through IVF and have done pre-implantation screening, which does carry a 1% to 2% risk for mosaicism. I think it's still worth having the conversation so they're informed on what's available. Right now, non-invasive prenatal testing is not recommended for twins because it has not been validated in the twin population, so we should not be using it for twins. However, sequential screening, the use of an NT, and even diagnostic testing in certain scenarios is appropriate, and patients can be referred for genetic counseling if there's any questions. We can try to reduce the risk of preeclampsia by starting a low-dose aspirin at 12 weeks, and we can consider screening for gestational diabetes in higher risk patients early between 20 and 24 weeks, and if that's negative, again at 28 to 32 weeks. I usually introduce the differences in delivery management at that first visit just to sort of set the stage for what's to come. And I actually find that most families already have those questions for us or for me. And so that's usually built into my first visit. While we typically think of fetal reduction as something to offer in higher order multiple gestations, I've had families have been curious about what that means, and we at Northwest Perinatal are happy to talk with families about what fetal reduction would entail and what the potential risks and benefits are. But I think it could also be considered in the twin gestation where there's a particularly high risk based on a maternal comorbidity or even a co-fetal comorbidity in order to reduce the overall risk to the pregnancy. For example, a patient who is undergoing IVF therapy and has a renal transplant and is already at very high risk for complications from that underlying medical comorbidity. And finally, I usually establish an ultrasound surveillance plan with the patient and set up kind of the expectations for the visits to come based on the type of twins that they have. So with that, I'm going to focus on dichorionic diamniotic and monochorionic diamniotic twins and what surveillance would look like. So usually we figured out they're having twins because they've had some sort of dating and viability ultrasound or genetic screening in the first trimester. Beyond that, all twins should have a detailed anatomy ultrasound because of the increased risk for aneuploidy and congenital anomalies. We're usually completing that around 20 weeks. If it's been an IVF pregnancy, an echocardiogram is indicated at 22 weeks, or if it's a monochorionic gestation, around the same time point. With dichorionic diamniotic twins, there's no standard recommendation on how frequent growth ultrasounds should be done, but it's considered reasonable to do them every 4 to 6 weeks. And twin growth tends to slow around 28 weeks, so starting at around that 26 to 28 weeks is reasonable based on ACOG guidelines. And delivery for dichorionic diamniotic twins without any other complications is usually targeted at 38 weeks. For our monochorionic twins, we're doing growth ultrasounds every 4 weeks and beginning antenatal testing on a weekly basis at 32 weeks. And we deliver them a little earlier at 37 weeks. So this is a sample screening schedule, just a potential outline for what it would look like for a dichorionic diamniotic gestation as well as monochorionic monoamniotic gestation. Of course, with your di twins, if you have a maternal comorbidity that would prompt you to schedule antenatal testing, then that should be done when it would be done for that comorbidity. All right, lastly, I just wanted to mention a few thoughts on when we could see twins over at Northwest Perinatal. Of course, we're happy to see any twin gestation, or if there's ever a question that that we can be a useful resource for you. Potential reasons to refer may be monochorionic twins or monoamniotic twins for management. If you're unsure of chorionicity or amnionicity, higher order multiple gestations, any family who has questions about multifetal reduction, and the twins that are experiencing growth restriction or discordant growth would be another very reasonable reason for us to see them for at least a one-time consultation. Thank you.